Good day everyone, this is Senior Clerk Goldemir Israel, and in this video I will be showing you how to do the tracheostomy with the open surgical technique. Tracheostomy is the creation of communication between the trachea and the overlying skin. Indications for tracheostomy include the following. Before performing tracheostomy, one must perform a thorough preoperative evaluation, and this include the level of obstruction, the anatomy of the neck, the presence of coagulopathy, cardiorespiratory status, deviation of cervical trachea, and the presence of laryngeal cancer. Materials needed are tracheostomy tube, Cooper scissors, scalpel, mosquito forceps, muscle retractors, and tissue tweezers. Tracheostomy is best done in the OR with good lighting, instrumentation, and assistance. Place the patient in a supine position with the neck extended by a pillow or a bag placed under the shoulders. This is done to give adequate access to the cervical trachea. To begin, sterilize the skin in the anterior neck and the chest. A local anesthesia is then administered. Drape the neck. If the tracheostomy is done under local anesthesia, the face can be uncovered. The tracheostomy is created below the first tracheal ring to avoid subglottic stenosis. Run your finger up the midline of the neck starting inferiorly at the sternal notch. The first prominence encountered is the thyroid isthmus followed by the cricoid. Make a horizontal incision 2 cm above the sternal notch. Extend the incision through the skin, the subcutaneous tissue, and the platysma. Take care not to transect the anterior jugular veins. Dissect the trachea by parting the tissues. Remain strictly in the midline in a vertical plane to avoid injury to the inferior thyroid veins. You can now identify the midline cervical fascial plane between the sternal hyoid muscles. Divide this intermuscular plane by spreading. Repeat this maneuver to separate them and retract the muscles laterally. Now the trachea and the cricoid can be palpated. If the thyroid isthmus overlying the second and the third tracheal rings is encountered, retract the isthmus superiorly to expose the trachea. In exposing the infrathyroid trachea, carefully part the overlying pretracheal fascia with a pair of scissors. Take care not to tear the inferior thyroid veins. Now ensure that the surgical field is completely dry before proceeding. If there is a doubt whether it's trachea or a carotid artery, aspirating air with a needle attached to a syringe will confirm its location. Create an inferiorly based flap raised from the anterior wall of the third and fourth tracheal rings. This is the safest tracheostomy in adults. After the flap is created, a silk traction suture is passed through the anterior tracheal flap, which is loosely secured to the skin. Assess the size of the trachea and select the largest cuff tracheostomy tube that can fit the tracheal lumen. Inject air into the inflatable cuff of the tracheostomy tube to test for its integrity. Insert the tracheostomy tube under direct vision while applying traction to the suture attached to the tracheal flap. Ensure that the tube has been inserted in the tracheal lumen and not in the paratracheal soft tissues. Remove the obturator and insert the inner cannula. Hand ventilate while confirming for the correct placement of the tube within the trachea. Check for the expired PCO2, chest movement, and breath sounds. Secure the tracheostomy tube by threading tape for the fenestrations and flanges of the tube. Pass them around the neck and ensure it is tied with the neck flexed. The tie should be tight enough to admit no more than a single finger under the tape. The tracheostomy tube is then sutured to the skin for the first few days. Until there is maturation of the tracheocutaneous shaft, the sutures can then be removed. Complications of tracheostomy can be immediate or late, and these include the following. That's it for this video. Thanks for watching.